Thank you all very much. You know who I am, so I'll jump right into the presentation. Strata has been focused on system flow navigation for, as I said, 20 plus years, starting in Canada with the likes of Alberta Health, and we're really proud of some of the global partners that we've seen over the years through America, obviously into England and even Canterbury, New Zealand. Now, our logic model looks a little bit like this, and you stand back and go, whoa, that's an eye chart, and it's daunting, and is there ever a lot there? You should see the logic model of a manual system. It's about 5 times more chaotic than that. But the reality is, I'll break it down really simply here. On the left-hand side, you've got senders. It can be hospital, it can be primary care, it can be community services, NHS 111, ambulance. All of these senders have a patient that needs a transition of care. In the middle, you've got functionality through Strata Health, which I'll talk about in a second, 3 core things. And then on the right-hand side are the receivers. And again, it can be anywhere across that care continuum. So when you start to move and mobilize patients through a complex system, through an ICS, which is health and social care and social prescribing, you need to be able to coordinate that to optimize that patient's transition. And of course, all of this is integrated, launching out of native EPR systems, navigating through all of those different nodes, and then pushing it back into native systems underpinned by a shared care record. So this fits with those macro strategies within the NHS. Year on year, we continue to spend more and more money in healthcare. We have to. Population goes up. People are aging. So where do we spend that money? Well, Britain is only number 2 to the US in terms of the most money spent as a percentage of GDP in hospitals. So it's targeted usually at hospitals. Kind of makes sense, I think, but I also think that we need to broaden that out and look across that care continuum. And here's why. At any given point in Britain right now, in England right now, there is over 13,000 patients that no longer meet the criteria to reside in hospital. That's right now. And the Department of Health and Social Care says that's about a £7 billion a year issue. And we need to fix that. And we need to fix it because it's expensive, but we need to fix it because it's the wrong place for 13,000 patients at any given time. And 10% of those are palliative. You don't want your folks passing away in hospital, I can tell you from experience. So what you need to do is open up access to all the different levels of care and get the right patient into the right place at the right time. A metaphor would be a wash basin. And there's only 2 ways to make sure this doesn't overfill. One is turn off the tap, the inflow at the front door, or 2, open up the aperture, the drain at the other end, and let it flow. So if that was a hospital, you could throw more tech, you could throw more FTEs, you could throw more beds at it, but you're not going to enable a greater capacity in that set wash basin, in that set hospital. So the first really proud case study and best practice that I wanted to mention was East Lancs, and we automated mental health and the access to mental health liaison team through the front door of ED. And so we've got 350 referrals a month going through this system where there wasn't access to mental health before. And so it really has an impact on patient well-being and care, and it helps to kind of, again, turn that tap off on that front door. Next steps here is we're going to be bridging that into primary care and opening up new wards as well. The second piece is at that back door. So it's Trusted Assessor. And this is about trust. This is about the teams working together in East Lancs Hospital with the ICS partners and stakeholders. And this has been so impactful. We've got over 300 people using the system at any given time. And we've automated 8 different care streams, which has a profound effect. And if Andrea was here with us today, she'd say that this is indeed a brilliant step forward in integrating discharge and discharge services and working as a team. So that trusted assessor, it's in the name. It's about trust. It's about getting efficiencies in the system. It's about trying to really harness and work as a team together. So I say referral, and really quickly I say, is this really about referrals? No, it's not. It's about transitions of care, which is an enabler to case management, which is plan, implement, monitor, and evaluate. Don't think of referral, fire, and forget. That's not what we're talking about. We're talking about mobilizing patients in the right place at the right time. Those three things very quickly with Strata that we do that are unique in that process, that first eye chart I showed you, those three circles in the middle. The first one is we've got algorithms that are AI enabled. And so obviously we will match the clinical need, but we will match to other key elements as well, like patient preference, geolocation, wait list management. So these are things that optimize placement downstream for the patient and the care system overall. The second thing is capacity in the community. So you can match a patient, say, out of all the different combinations and permutations across an ICS, here are the things that we really need to deliver on for case management. But yeah, that's great. Is there capacity downstream? And this isn't an old newspaper. This isn't something that we're getting ad hoc saying we've got this many beds or this much availability in our caseload. This is the system churning out real occupancy and vacancy numbers so that you can make good and just decisions in transferring that patient. And then lastly, monitoring the progression of the care plan or delivery. And so it's who's accountable, what's been done, what's yet to be done. It's a little bit like if we can order something on Amazon and watch as that parcel gets picked and it's to the post office, it's on the truck, it's delivered to the front door and you open it. Why the heck can't we do that with patients? We need to be able to know exactly where they are, be able to communicate that back to their families as well. So those are the three things that are amongst a number of other things that are really unique about the Strata model. And then of course pulling that into dashboards, whether that's a unique dashboard like you see here for Strata, or pushing it into a data lake so that you can cross-cut it with other information. But really important to, again, get the right patient into the right place at the right time. And that's me.
Brilliant. Very good. Thank you, Ken.
Thank you.